Good afternoon. I would like to thank you very much and for your attention, and also for the Arizona Trauma Association for giving us the opportunity to present our study on the amniochorionic membrane and healing of limbs that in the past, in our institution at least, have been amputated, but now we have found a method where at least in certain cases we are able to salvage the limb and not amputate. So basically, burn and trauma limb injuries with exposed bone and tendon often require surgical flaps, or they have to have amputations, because it's very difficult to put a skin graft on top of just pure bone or tendon. There's no granulation tissue and no vascularity with which to basically keep the graft down and vascularize the graft. In my situation, I'm a pathologist and I do research in burn and hematopathology, and it's been a full circle, especially similar to that a lot of people here who are in my age group probably have gone, because in the past I used to, 30 years ago, examine placentas, and now I am seeing the placenta producing cells and healing factors for wounds and saving limbs. So it's been very exciting. But this has not been a new development, because Dr. Sabella in 1913 was one of the first people to use the placenta tissue in order to create the vascular granulation bed for the skin grafts to maintain themselves and heal the area. Then Dr. Schlanzer worked with Integra for a traumatic degloving and desiccated bone, and he basically also used it. And then amniotic membranes were also used by Dr. Lyons for full thickness skull bone defects. So what do we do? Basically, you think of if you've been in a delivery, and most of you probably have been in a delivery, when there's a baby that comes out and then the placenta comes out, especially through the vagina, it's very, very, in some cases, dirty. So you really don't use that type of placenta tissue for this situation. They have developed methods in which they can actually cleanse and prepare the placental tissue just like they do the heart organ or the bone or the tendon that's used for grafting from the donors. So nowadays, they go to women who are going to have a normal delivery, and they test these ladies just as much as they would test the organ donor tissue to make sure there's no hepatitis, no HIV, no Western Nile virus. And what they do then is they have the consent form, and then they have a process method called the Purium. So DHACM stands for dehydrated amniotic chorionic membrane, and that's basically that membrane that encases the baby. And this particular tissue contains non-viable cells and over 285 identifiable proteins. Growth factors, stem cells, well, those are probably non-viable, but they're still in there, cytokines, and metal proteinases, tissue inhibitors. And this has been very successfully used for a number of years for ulcers, burns, donor sites, and surgical debridement. And then what they do is they also take the chorionic plate, that spongy material that is basically connecting the baby to the mother, and they they create it in such a way that they keep the cells there with all of those specific factors, and yet they make it into a nice sheet. So the DHACM is basically like a powder that comes in a vial, and the other one comes as a sheet. So this is basically derived from the disc, which is the chorionic plate, the spongy part, and it contains a lot of the type 1 human collagen. So how do they do it? Well, first they have to clean the area. And we're going to see in a few minutes a number of these cases. And in order to provide some vascularity in the area where the exposed tendon and bone are, they have to burr the bone to basically provide some vascular supply to the area to provide opportunity for the granulation tissue to form. So once they have gotten a clean surface, they've burred the bone, they then put the HACM, and in our center, we first put the powder down, and then we put the sheet of the chorionic membrane on top of that, and then we put a gauze over it, a petrolatum gauze, and then on top of that, in order to promote the healing, which we all know is very effective with negative pressure wound therapy, we put that on top so that it sucks all of the juices from the patient's tissue and provides good opportunity for the bad stuff to be removed, keep it nice and clean so it doesn't become infected, and also provide the nutrients from the individuals themselves in addition to that cellular, the amniomembrane component that, and the chorion that is put down from the placenta. And then every 7 days, they look for what the tissue response is, and then if it needs reapplication, then they reapply some more of that material, but in the meantime, they do the negative pressure therapy on the regular basis. So what we have so far, at least at the time this was prepared, we had 8 individuals. The average age of these individuals was 50 in terms of the median and 54 as a mean. Most of the time, these are small injuries. They're not that big, but yet one is surprised that for such a small injury, one would have to amputate a limb or an extremity. The length of stay in the hospital because of the cleansing process to make sure the tissue is clean and ready to produce the granulation tissue with the help of the amniochorionic substance. It's usually a median of 38, but it is basically a mean of about 2 months. And then they do the tangential excision and debriding. How many times do they have to do it? It's usually about 8. This is prior to application of the tissue, in order to prepare the surface of these injuries for the acceptance of this covering. So when you look at this, the injury to admission, how long does it take for the preparation? They come in, it usually takes about 22 days or a month. And then from the application of the tissue, how long does it take before the grafting can be done? And that's usually about 2 weeks, and in some cases it's almost a month, depending on how deep that tissue injury had been. And application of the material to the discharge is about 18 days or about 3 weeks, and negative pressure wound therapy days is about 15 days. So this is all the daytime requirement for this process to do well and for the patients to come out with autografting instead of amputations. So just to give you some example, this is case 1. This was an elderly gentleman of about 77 years old who was a little dizzy and fell on his space heater. And not really paying attention, living by himself, he didn't really go to the emergency room or the hospital at a convenient early time, but delayed a bit, and he ended up, as you can see, with a lot of necrosis along the leg, which was spreading since the time that he had fallen on the space heater. You can see here that he had a very, very nice layer of granulation tissue. And when you look at the following slide, you can see that he is now ready for grafting. The very interesting thing here is that there is still some tendon that is not being covered, or basically boned probably, that is not being covered here. So when he healed with the graft, that area was still exposed. So what the doctors did, they just applied some more of the amniochorionic membrane and provided him with more treatment. And then you can see here that even without any further grafting, he basically healed he healed very nicely. Does everybody see that? So he healed very nicely. So how long did it take for him? They were trying to use Integra at the time. Time for me to stop?
Getting close.
Getting close. Okay. So then I'll show you the next patient. So this is a patient who had some coffee spilled on him, and you can see here very nicely that the tendons are exposed. And then this is the covering with the petrolatum dressing. Here's his wound therapy, wound pressure therapy, and he is healing very nicely here, so he didn't have to have an amputation. So conclusions. Our patients basically are doing very well, followed up in clinic. The wounds healed after 2 to 3 applications and did not require leg or foot amputation. The treatment may be continued with the NPWT therapy at home or in the skilled nursing facility. So if that's available, then they don't have to stay in the hospital that long. So this might be a very promising alternative in terms of not amputating, but actually spending time and treating the patients on this basis. Thank you very much for your attention.
I'd like to invite Dr. Filler here to present to us deviation of a standardized method to identify the anterior compartment of the lower extremity using point-of-care ultrasonography.
Hello. So my name is Levi Filler. I work at ValueWise Health in the Department of Emergency Medicine, formerly Maricopa County. I was very grateful to have completed my residency training in emergency medicine, as well as my follow-up training as an ultrasound fellow. And before I get started, I'd like to thank Mark Matthews, Carl Mitchell, and John Porter for assisting with the study and making some of this possible. Today, I'll talk about derivation of a standardized method to identify anterior compartment of the lower extremity using point-of-care ultrasound. So a couple of objectives as I go through this. I'd like all of you to understand a couple of pearls and pitfalls in performing lower extremity fasciotomies, as well as some techniques associated with it. Realize the utility of point-of-care ultrasound in the realm of surgery, and understand how to identify the anterior compartment of the lower extremity. Become familiar with soft tissue and musculoskeletal point of ultrasound, what it appears under ultrasound, and some of the features of the findings of the lower extremity. So a little bit of background for you. As you all are very familiar, acute compartment syndrome was originally described by Richard von Volkmann in 1881. He was the first to cite the literature, but not the first to describe it. The most common location for acute compartment syndrome is the lower extremities, with tibial fractures being the most common cause, in approximately 36% of this. Incomplete fasciotomies can lead to serious medical complications, including chronic pain, neuropraxia, and foot drop. And there are also significant legal risks associated with this as well, with a couple of most recent literature citing the average indemnity payment for missed compartments as well as delay to fasciotomy upwards about $500,000. So the traditional treatment for lower extremity compartment syndrome is a 2-incision 4-compartment fasciotomy. There have been previous methods and techniques that have been described in the past. However, this most commonly is the most preferred method. So it can be accessed by an incision approximately 2 centimeters lateral to the tibial crest. However, it's been shown in previous literature that if you make an incision too close to the tibial crest, even as far as 1.5 centimeters away, you can risk damage to the common peroneal nerve as well as vascular perforators. There have been other methods as well. So a previous method has also been described. If you make an incision overlying the fibular head, approximately 2 finger breadths anterior to this, as well as extending your incision at the mid-leg, that would allow for access to both the lateral and anterior compartments. However, if you make an incision over the fibular shaft or even posterior to this, that risks actually missing the anterior intermuscular septum, and you can mistake the posterior intermuscular septum for the anterior septum instead, and thus missing the anterior compartment decompression. So brings me to my point that the anterior compartment of the lower extremity is the most frequently missed compartment during fasciotomies. So we wanted to ask ourselves, could this be improved, and what methods could we use to actually improve our miss rate? So our goal was to utilize point-of-care ultrasound to identify the anterior compartment of the lower extremity, and using this we would derive superficial skin measurements that would correlate with the optimal site to perform an extremity fasciotomy to successfully release the anterior compartment. So what we did at our facility was we took approximately 94 healthy volunteers at our institution. We obtained biometric data to account for differences, including age, weight, height, BMI, as well as leg length, in an attempt to standardize our methods. So the study was performed by 2 emergency medicine trained ultrasound fellows, including myself. All of the images and measurements that we obtained were validated by a third party, including a physiatrist, a burn surgeon, and an ultrasound trained attending as well. We confirmed our findings with a validation set of approximately an additional 100 individuals. We excluded those with any prior lower extremity infections, surgeries, orthopedic hardware, or DVTs, or anything that would disrupt fascial boundaries or soft tissue. So we utilized a linear probe from the ultrasound machine, which is a very high frequency probe. It provides excellent resolution for superficial structures, and it's been used in the past for soft tissue and musculoskeletal applications, as well as vascular applications as well. We used it to define the fascial boundaries of the anterior compartment, and this is what we got. So the image on the right, or your left, or your right, is the ultrasound image of the anterior compartment using the linear probe of the ultrasound. So what we ended up doing was we derived both superficial as well as ultrasound measurements and marked them on the skin surface. So the image on your left is a lower extremity, and there are a few letters there that denote a few of the markings that we obtained. So A represents the line that represents the lateral edge of the tibial crest at approximately 6 centimeters distal from the tibial tuberosity. So that is a very well denoted landmark that you can use with palpation, just using physical exam. And C is the line that we denoted from measuring basically the fibular head to the lateral malleolus, and we call this the axial line. So it's basically an arbitrary line as a standard reference point for the remainder of our measurements. So those, both A and C, were measurements that we were able to mark on the skin just by using physical examination. The marks B and D were actually the extrapolated findings from the musculoskeletal ultrasound that we obtained from the image on the right. So the image on the right, the red dotted line, is actually the boundary of the intercompartmental fascia of the anterior compartment, and everything medial to that is the actual anterior compartment itself. So B represents the intercompartmental fascia of the anterior compartment, and D represents the lateral compartment. So by using ultrasound, we actually extrapolated the markings to the skin surface in order to create our measurements. So some of the results that we obtained, we found that the mean distance to the anterior compartment from the axial line was about 2.77 centimeters, which is very useful because in previously described literature, about 2 centimeters from the tibial crest is about where the anterior compartment would lie in the past. So it was very similar to this measurement as cited in previous literature. We also found that an incision that was made about half the distance from the axial line to the lateral edge of the tibia would result in approximately 98 incisions falling on the anterior compartment and 3 in the lateral. Furthermore, we found that an incision about 2/3 of the distance from the axial line to the lateral edge of the tibia would result in almost all of the incisions falling in the anterior compartment and only 1 in the lateral compartment. So given these findings, we created a validation set, which included volunteers that were generally similar in terms of biometric data, and we took about 100 of them and reproduced our findings. So the point of interest, about 2/3 the distance from the axial line to the lateral edge of the tibia, fell on the anterior compartment in all of the 100 lower extremities that we studied. So, in conclusion, we found that an incision that's approximately 6 centimeters distal to the tibial tuberosity and 2/3 the distance from our axial line, which remember is our line drawn from the fibular head to the lateral malleolus, results in the most optimal location for initial access to the anterior compartment. So we found that the fascial planes of the anterior compartment can in fact be identified under ultrasound, specifically with the linear probe, and is identified with 100% accuracy when using both physical examination landmarks as well as sonographic methods. This can result in the reduction, hopefully, in the number of missed anterior compartments with fasciotomies in the setting of acute compartment syndrome in the future. We did have some limitations to our study. We used a very healthy study population, so we cannot extrapolate to those with actual compartment syndrome themselves. And we cannot extrapolate our findings, obviously, to other compartments. Additionally, we did not identify the perineal nerve or any vascular structures or perforators during our study as well, which kind of effectively sets us up for future studies later on. Any questions? Thank you.
I'd like to invite Dr. Shaikh up from Nassau University Medical Center for Unraveling Quad Fever, a review of severe hyperthermia after traumatic spinal cord injury.
Hello, good afternoon, everyone. My name is Dooniya. I'm a third-year surgical resident from Nassau University Medical Center in Long Island, New York. I'd like to thank the committee for giving me the opportunity to speak today. I'm going to be presenting a retrospective review that we did at our Level 1 Trauma Center. This is Unraveling Quad Fever, a review of severe hyperthermia after traumatic spinal cord injury. I have no financial disclosures or conflicts of interest. Before I start, I want to give a background onto why I wanted to study this pathology. As a mid-level, one of my first calls, I got a call from the intern in the ICU saying, I have a patient that has a fever of 108. The first thought that went through my head, obviously, was, please check that again. He called me back and said that indeed the patient's fever was 108. This patient had a cervical spinal cord injury after an MVA. After doing some research, I found that there is a pathology called quad fever. This was first described in 1982. It's an extreme elevation in body core temperature in patients with spinal cord injury. This is a rare occurrence, and it's indeed a diagnosis of exclusion. You have to exclude infection, malignant hyperthermia, neuroleptic malignant syndrome, thromboembolism, and any type of medication-induced fever. So in terms of the literature, there is very little that's out there. There's a couple of case studies and case series that have been reported. The timeline and when these patients get this high temperature is variable. It's as early as hospital day 1 to hospital day 23. The temperature set points in terms of the definitions are variable as well. In some literature, it says you can start considering it at a temperature of 101 Fahrenheit. Some say that you should consider it at 105. In terms of our study, we set our definition for quad fever at 104 degrees Fahrenheit or 40 degrees Celsius. The spinal levels at which the injury occurs causing this type of fever is variable as well. It's usually more commonly found in quadriplegics, however, it has been seen in paraplegics as well. The pathophysiology is unknown. There's thought to be autonomic dysregulation in afferent and efferent pathways in the spinal cord that get disrupted during these injuries, and the mortality is very high, up to 100%. So in terms of our study, after we identified this one patient, we tried to identify if there were any other patients that we had missed or we had seen this pathology in. We did a 9-year review in a retrospective study finding any patients that had spinal cord injuries, paraplegia, cervical contusions, or lacerations. We looked at these patients, at their demographics, their clinical data in terms of their labs, the treatments that they got, whether they got antipyretics, cooling blankets, and in a treatment modality that we are focused on is the Arctic Sun, which is an external dry water temperature management system, which I'll go over in a little bit, and the outcomes that they had, what kind of morbidity and mortality that they had. Our inclusion criteria was any patient that was 18 years or older and had verified CT and MRI imaging demonstrating the spinal cord injury. We excluded any patients that passed away in the emergency department or the disposition was anywhere else besides the surgical ICU. We also excluded anyone with positive blood cultures, as this could not give our diagnosis of exclusion for quad fever. We further divided our patient population into 2 cohorts. The spinal cord injury patients that had temperatures above 40 degrees Celsius and the ones that were below. The ones that were above were considered quad fever, and the ones that were below were not quad fever. I realize this is a very complicated table, but just to go over it step by step, the mean age in our whole population, we found 35 patients overall over the 9 years that had verified spinal cord injury levels that met all of our inclusion and exclusion criteria. The average age was 54, and there was no statistical difference between quad fever and non-quad fever. There was a male predominance overall, and our quad fever category had no female patients. Our quad fever category did have 7 patients overall. The temperature max obviously had a statistical difference because that's how we divided the 2 categories. In terms of mechanism of injury, the majority of the patients were either MVC or fall. However, there was no statistical difference that divided the quad fever and non-quad fever categories. The spinal cord injury level injury was categorized from C1 to C4, C5 to C7, and then anything below C7, below C7. We found that 85.7% of our quad fever patients were in that C5 to C7 category. Although not statistically significant, this did give a clinical trend. The same thing was found with the Asia score. We found that 71.4% of our quad fever patients were an Asia score of A. This is a score kind of delineating how bad the motor and neurological dysfunction is in the patients, an Asia score of A being the worst. The GCS had no statistical difference, and the injury severity score was higher in the quad fever category as opposed to the non-quad fever category, but this is also a clinical trend and not statistically significant. Further analyzing the patients, the surgical ICU length of stay in the quad fever category was a mean of 20.9 days versus 6.1, which was statistically significant. And we used the Arctic sun in most of our quad fever patients, which was 6 out of the 7 that we had. The overall mortality between the two patient populations was 21.4% in non-quad fever and 57.1% in quad fever. This is statistically not significant, and this is kind of a backwards way to look at it, but innately, being at a temperature above 104 or 40 degrees Celsius gives you a pathophysiological state of shock. You're coagulopathic, your organ systems shut down, and you are innately at higher risk for mortality. And we think that the use of our Arctic sun treatment modality helped our mortality become comparable to the non-quad fever category. Taking a closer look at our quad fever patients, this is a table showing all the patients, and it's stratified based on lowest temp to highest temp. And as you can see, there's variable white blood cell counts. Some are normal, some are high, so there was no trend that we found in the white blood cell count. There was no trend that we found whether patients got surgery or not. And all of these patients did have respiratory cultures. The reason we didn't exclude positive respiratory cultures is because even in ICU settings, it is unlikely that you find patients that get to temperatures higher than 40 degrees Celsius, even with positive respiratory cultures or respiratory infections. And out of the one patient that did not receive the Arctic sun, that was one of the patients that did have the mortality. To go over in summary, in terms of all of our cervical spinal cord injury patients that we reviewed, we found 84 overall, and we brought those down to 34 patients in our population that we looked at, making our incidence 8.3%, which is comparable to what is found in literature, which is about 8%. Our average onset of hyperthermia was on hospital day 4. Our surgical intervention did not correlate with having quad fever. Clinical trends that we found was that there was a male predominance. The severity of the Asia score, A being the one was clinically significant, as well as lower cervical spinal cord injuries were found in quad fever patients. The mortality rates were comparable between the quad fever and non-quad fever. Just to talk about the pathophysiology a little bit, what's found in literature right now is that we think that there's a disruption in the hypothalamic, afferent, and efferent pathways. Another thought process is that there might be a hyperadrenergic hypermetabolic state. This is observed after traumatic brain injuries. There's an innate elevation of CSF PGE2, which stimulates the hypothalamus, causing hyperthermia. We even propose that there might be a role of the vagus nerve in this severe hyperthermic reaction. The vagus nerve is known to have a pathophysiology in reacting to any abdominal interleukins and creating that pathway back into the hypothalamus and eliciting a response. We think that the vagus nerve in these cervical spinal cord injuries might be irritated just by being in the vicinity of the injury that could be a cause of the hyperthermic reaction. The treatment modality that we use is a dry water temperature management system. It's called the Arctic Sun. It uses varying water temperatures and sophisticated computer algorithm to control temperatures as close to 0.2 degrees centigrade. It's different than cooling blankets. You can set the temperatures at which you want to start the machine and at which point you want to stop the machine as well. It uses circulating chilled water pads that are directly adhered to the patient skin. It's usually clinically used for therapeutic hyperthermia and cardiac arrest patients. However, we've had very good positive outcomes in using this treatment modality in our hyperthermic patients. In conclusion, we think quad fever warrants high level of suspicion in the setting of hyperpyrexia in cervical spinal cord injury patients. The pathophysiology requires further study, and the use of the non-invasive dry water temperature management should be used early for positive outcomes. Thank you. Thank you.
I'd like to invite to the podium Dr. Liu from Maricopa Integrated Health System for presentation of Has Illicit Drug Use Increased the Severity and Economic Burden of the Trauma Patient in an Urban Center? Dr. Liu?
Good afternoon. My name is Wendy Liu, and I'm a general surgery resident from Valleywise Health Medical Center, formerly known as Maricopa Medical Center. I would like to thank STACS today for the opportunity to present our study. Today we will be asking the question, has illicit drug use increased the severity and economic burden of the trauma patient in an urban center? There's no question that the opioid epidemic is a hot topic of today. As prescribers, we are in the midst of the problem and the solution. This graph here depicts the trend of opioid prescribing over the past 11 years, with a steady increase of an average days of supply to a little more than 18 days. During the past decade, we have seen a rapid rise in opioid and drug overdose deaths. In 2018, according to the U.S. Department of Human and Health Services, about 130 people die from opioid-related overdoses every day. 40% of these overdoses are actually secondary to prescription drugs. And you can demonstrate that here by the blue line. This figure illustrates the dramatic increase in death from synthetic opioids such as fentanyl. In addition, there's also noticeable increase in death in semi-synthetic opioids such as hydrocodone and oxycodone, and heroin up to 5 in 100,000 deaths. The population abusing opioids have increased in nearly all age groups. What this figure here shows is a more significant rise in drug overdose deaths in the 25 to 54 age group with a steeper curve incline. So it's no surprise to any of us that there is an increase in substance use in the last decade. So the purpose of our study is to measure the impact of substance use on the injury severity score, as well as the cost to our patients and our society. We hypothesize that as polydrug use increases, we will start to see a correlation with higher injury severity scores and treatment costs at our urban center. The study we performed is a retrospective review of our Level 1 Trauma Center registry from the years 2010 to 2018. There was a total of 19,547 patients. 6,085 were positive for either ethanol, one or more illicit drugs, or both. 83% of our traumas were blunt, 17% were penetrating. 46% of our ethanol and or drug-positive patients had an injury severity score of 6 or greater, and 54% with an ISS less than 6. Our inclusion criteria was everyone that was 18 years and older and had data available for their length of stay, their injury severity score, hospital charges, the injury type, alcohol and drug positivity, payer source, their living status, and then their discharge plans as well. And these are the results that we found. So of our 6,085 patients, 23% were positive for ethanol only, 21% were positive for ethanol and drugs, 30% positive for a single drug, and 26% positive for polydrugs, more than one drug. The ISS, interestingly, is the same across all 4 different groups. However, you can see a noticeable increase in the average length of stay in the single drug and polydrug group compared to groups where ethanol was involved. As you would expect, this then reflects on the maximum and medium charges of the single and polydrug group compared to the ethanol positive groups. If we take the single and poly drug group and we look at the individual drug usages and dissect it a little bit further, we can see that opiates is the obvious front runner in the single drug group, followed by cannabinoids and benzodiazepines. The most common polydrug combination is a split between opiate and cannabinoid and opiate and benzodiazepines. One limitation of our study is the difficulty in differentiating between pre-hospital and admission-acquired opiates compared to street-acquired opiates. And in the literature, it's very difficult to discern the differences between pre-hospital as well as the compared to opiates that were obtained prior to coming. We then looked at our data and separated amongst different time groups. We looked at the timelines between 2010 to 2013 versus 2014 to 2018. Interestingly, we did see a decrease in trend with any ethanol use over time, but an increase in the single drug and polydrug use. Progressively, we see that patients are choosing to use illicit drugs and turning away from alcohol. This may be explained by the ease and accessibility of illicit drugs over the past 5 years. Diving further deep into the type of drugs being abused in trauma, we see an increase in all types of, except for benzodiazepines. The most significant increase between the early 2010s to the later 2010s is the increase in amphetamines and opioid cannabinoid combination. Interestingly, Northern Europe, such as Norway and Sweden, have also been dealing with an increase in amphetamine-positive associated traumas. However, they have not demonstrated as large of an opioid problem as there exists in the US. We then turn to look at how the change in ethanol and illicit drugs have affected the median patient's hospital charge per length of stay in the past decade. Ethanol and single drug group demonstrated an 8% and 4% decrease respectively from 2010 to 2013 versus 2014 to 2018. However, the ethanol plus drugs and polydrug group showed a statistically significant increase in charge during the same time period of 24.6% and 18.7% respectively, and these were statistically significant. This last figure here displays the payer source when we divide it into groups as well as the time frame. For nearly all groups except for ethanol only, there's an evident increase in the rise of Medicaid being the primary payer source. In addition, the self-pay patients have also decreased in every group between the earlier half of the decade to the later half of the decade. This increase in drug use is associated with a shift in societal responsibility as more and more patients are requiring government aid with hospital bills secondary to trauma. Earlier, we had hypothesized that the increase in drug use would be associated with an increase in injury severity score. However, from our retrospective review, we demonstrated that to be false. The ISS remained the same throughout all 4 different groups. We have seen an associated increase in hospital charge and length of stay in the ethanol plus drug group and polydrug group compared to the ethanol only and single drug group. We have also identified opiates and cannabinoids as the most frequently abused drugs in our trauma population. The opioid cannabinoid combination and opioid benzodiazepines have also shown themselves to be the most frequent polydrug. From our study, we demonstrated an increased hospital costs associated with illicit drug use and the associated burden that it has on our society. More work still needs to be done to combat the rise in illicit drug use, not only to help individual patients, but to help with the societal burden as a whole. Thank you very much.
I'd like to call our last presenter to the podium, Dr. Frank Bauer from HonorHealth Scottsdale Osborn Medical Center, to present chest wall stabilization in a patient with severe TBI, a case report.
Good afternoon, everybody. I'm Dr. Frank Bauer over at Scottsdale. Thank you very much for having me. Appreciate it greatly. So today we're going to talk about two different things that are not often put together, and that's chest wall stabilization and traumatic brain injury. So rib fractures are very common in trauma, especially in centers that see a lot of blunt trauma like ours. And 20% of patients with thoracic trauma are affected. We often see other things that are associated, hemothorax, pneumothorax, and it obviously differs in severity depending on how many rib fractures you have, whether you have a flail chest or not. And then that results in many different problems, including pneumonia, respiratory failure, atelectasis, other things that affect the treatment of your trauma patient. So for a really long time, we've basically done the same thing for these patients, which is giving them pain control, making sure that they're getting rid of their pulmonary secretions, and then supporting them with oxygen. It's not fair to say that we haven't been doing rib plating for a long time too, because it was actually originally done in the 1950s, but that was also the time when the mechanical vent really became a popular thing. And so the thought was that mechanical ventilation actually kind of stinted your rib fractures, and we went that way instead. Even in 1975, there was still trials coming out with this. In 1979, another study that was done with Kirschner wires, but it really didn't take off. Now recently, you can see on the graph, this is just showing how many studies that are coming out examining rib fracture stabilization, and the field is really exploding. So I'm presenting a guy who fell off a ladder while trimming a tree, which seems to be a common thing at Scottsdale. So his wife said he shouldn't have been doing that. His history was DVTs on Coumadin, but otherwise was pretty healthy for his age of 66. He came in with a severe traumatic brain injury with a depressed skull fracture, and for the first 48 hours, his GCS was measured between 4 and 7. After 48 hours, he started following simple commands. He also had pretty significant L1 and 2 compression fractures, and neurosurgery was consulted for that. The rib fractures that you see, bilateral scapular fracture. When he got to the trauma bay, he actually arrested, got intubated, received CPR for 3 minutes, and came back very rapidly. And our thought was actually that he had had a respiratory arrest, and that's why he responded so quickly. So he went to the ICU and was treated. And again, at about the 72-hour range, he started following simple commands and waking up a little bit. So we faced this patient and talking with the family extensively about the risks and benefits of stabilizing the chest. Felt like it was the right thing to do and ultimately plated his chest. So our approach, I think, is fairly standard, but some specifics of what we do. We do 3D recons on our rib fracture patients and then measure several respiratory variables. We follow the clinical guidelines that came out in Injury 2017, which are comprehensive and really go through a lot of the data and the evidence and pretty much anything that you can think of for caring for these patients. And then we often approach these patients multidisciplinary, so including ortho, thoracic, and the trauma teams. We use different types of pain control, including on-cue catheters, ESP blocks, and other things. One thing we do not do is thoracic epidurals at my hospital. And then we also do the standards of care that have been for decades, the mobilization, toilet, analgesia, et cetera. Ali Osman et al. Showed us how to do the muscle-sparing, minimally invasive thoracotomy. These are pictures actually from the study that he published, and that is what we try to do as well. One thing is that we don't do routine use of VATS, is another unique thing of our approach. So technical aspects of this case, these are actually the images, and you can see that he had anterior and posterior elements on both sides and greater than 5 flail segments. So we faced a little bit of a difficult approach. How do you do both of these sides? Our answer was doing it one at a time. We also did it that way. That allowed us to shorten our anesthesia time. We started with the easier side really to see how he would tolerate it, and then he did really well, and so we ended up doing the more complicated side second. We were able to get really good chest wall stability with just the lateral repairs, so that's what we ended up doing. As mentioned previously, he had unstable spinal fractures, and we did that as a secondary. And again, we spared the muscles and did as small incisions as we were able, and then we extubated him and actually had to work with him on BiPAP for about 36 hours before we were able to wean him. But ultimately, never required tracheostomy, never got a pneumonia, and we're about 90 days out and still has not required that. So, not something that we think about often. Why is that? That's because it's been excluded from all the trials, and there's a reason for that, and that's because brain injury alone pushes a lot of people towards getting a tracheostomy or a pneumonia. So with trials, you're trying to get really strict inclusion and exclusion criteria so you don't have things that would potentially push your data in one way. So severe traumatic brain injury has been something that has really been excluded from almost all the work that's been done previously. But when you think about it, rib fractures alter your respiratory physiology, and we know actually if you plate ribs, people improve a lot of respiratory variables immediately after the surgery, and then they often have associated pulmonary injuries, which causes hypoxemia, hypercarbia, and potentially ARDS. Pneumonia also happens in these patients with rib fractures, which leads to hypoxemia, fever and hypotension, and potentially ARDS. The other thing that you're looking at with rib fractures is potentially prolonged mechanical ventilation, which we know people on the vent, they get a lot more sedation, they're sitting in bed no matter how hard we try, and they work with therapies less. All those things, so on the left side you can kind of see things that all kind of feed into secondary brain injury. On the right side, things that matter more for patient care, but everything leads kind of towards poor patient outcomes. So, this is a study that's been out for a long time. It was actually an autopsy study that they did in Scotland, and they, interestingly, in their study did 60 to 88% of their people got autopsies, which I cannot imagine that this study would ever be done again because we don't do that. But they did full necropsies, the whole body, including the brain, and their criteria for pressure was pressure necrosis in the parahippocampoid gyri, but they also looked in the arterial distributions and graded for the amount of arterial ischemia that they saw. And so their conclusions were two things. Number one, that raised intracranial pressure and cerebral ischemia causes mortality. But the interesting thing was that there were a lot of patients that had arterial ischemia without raised intracranial pressure, so their thought was that cerebral perfusion pressure mattered almost as much. This is a study that was done in Virginia, also a landmark study that looked at severe traumatic brain injury in the first 48 hours after and looked at whether a patient had a hypotensive or a hypoxic event anywhere, and then if that had an effect on outcomes. The other thing is that severe traumatic injuries otherwhere in the body or age, we know those might just cause things that would be bad for a trauma patient, but they controlled for those. And they found that independent of their age or what other injuries they had, that hypotension had by far the biggest effect, but hypoxia also led to increased mortality. So that comes to the cornerstones of care for these patients, which is avoiding hypotension and hypoxia. So the current evidence for rib plating, again, there's a ton of data out there. There's very few randomized controlled trials, which is because it's expensive. These patients are a heterogeneous population, and it would take a lot of time to recruit the numbers to really control for very different variables and things. And so there are not a lot out there, but there are randomized controlled trials that especially show the benefit in flail chest. And then if you pool the data, that includes prospective cohort studies, retrospective cohort studies, and others, the pooled data also shows those same effects, which is reduced mortality for flail chest, number one, but then reduced ICU length of stay, reduced days on mechanical ventilation, pneumonia, and need for tracheostomy. The things that this paper noted was that it's really a focus on short-term results, when the person gets off the vent, when all these things are happening. So we don't really know what the long-term outcomes are, which might become a lot more important in somebody with severe traumatic brain injury because you're really caring more about those long-term outcomes. The interesting thing is that the randomized controlled data seem to move in lockstep with the observational data. So 50% of what we do for rib plating is actually not flail chest, it's for non-flail indications, and we don't have randomized data for that. However, I will say that that's coming out soon. And a guy named Parachi out of Denver, who has really been the champion of this, and his non-flail study just closed, looking at greater than 3 severely displaced acute rib fractures, greater than 50% of the bicortical width. And so I really look forward, I'm sure a lot of you guys are really looking forward to those results to help tell us whether we've been doing the right thing with 50% of those patients. The final thing I wanted to address, this guy was old, he was 66 years old. Jerkovich showed in Washington a while back that rib fractures in the elderly is very deadly, and I think it's because it leads to the pneumonia. And so an additional risk factor that this guy had was his age. And so it's another aspect of this guy's care that he might actually be the guy that benefits more from rib plating than other people in the heterogeneous population. So the bottom line is we don't have enough evidence yet. I think it does make a lot of sense from a pathophysiologic perspective why we might consider rib plating these patients. And I also get why we haven't done it so far, because the severe traumatic brain injury might be the dominant thing that defines the outcome of the patient. So we don't advocate that everybody in this room just go out and rib plate everybody with severe traumatic brain injury, but we do think that there should be more study in the area, and it might ultimately become a relative contraindication. This guy, he's conversing with his family, he's able to ambulate with a walker, he's able to feed himself, do simple tasks of daily living. He definitely has a severe traumatic brain injury. He used to keep the books for his family. He's definitely not going to do that anymore, but he will have a quality of life. So in this patient, I do think that we ultimately ended up helping him. One of the final things that I would say, and it comes from those original studies, the intracranial hypertension might be the thing that really defines whether a patient does well or not. And then again, also, I think that early trajectory, if somebody's showing you improvement, it might be more reasonable. So thank you very much for listening. I'd like to thank Dr. Hu, who is the original plater at Osborn and paved the way for us. So, again, thank you very much for having me. And I thank all the people that helped me, including Dr. Najafi, who's over there, Toomey Allen, Miller, Kepros, my TMD, and Melissa for help.